Hello, my name is Joanna Barroso. I'm a pain neuroscientist at Northwestern University, where I work as a research assistant professor. And I'm also a pain clinician, currently a fellow at the Pain Clinic, Northwestern University. Today, I'm going to talk to you about imaging research to clinical care, advancing pain treatment options. I have no relevant disclosures, and I invite you to see two other talks for related topics presented by Professor Vanya Karian and Professor Paulo Branco, also present in this book. During this talk, I'm going to introduce imaging in pain research. I'm going to talk to you about the main techniques that we can use in MRI for research, the applicability of these techniques in pain research, and also what are the future directions that this field allows us to go on to clinical and science in the future. Imaging allows us to study brain function and pain processing. However, it's important to recognize that neuroimaging is just one of many techniques used to study pain. Other methods include electrophysiology, behavioral assessments, genetic studies, and animal models. Each approach offers unique insights, and a comprehensive understanding of pain mechanisms requires integrating these findings across multiple methodologies. And while neuroimaging provides valuable spatial information about brain activity, it has limitations. Therefore, a multimodal approach combining various techniques is often necessary to gain a complete picture of pain processors in the brain and body. In any case, the topic is imaging. So that's what I'm going to talk to you about. So what categories of imaging are available in the field of pain research? Several indeed. Medical imaging encompasses a diverse array of technologies that can be broadly categorized into structural, functional, and molecular approaches, each offering unique insights into human biology and disease. Structural imaging techniques like MRI and CT provide detailed anatomical information, while functional imaging methods, such as fMRI, reveal dynamic processes and brain activity patterns. Molecular imaging, including PET and SPECT, allows visualization of specific molecular processes and biochemical activities within tissues. Additionally, there are special techniques like diffusing imaging and magnetic resonance spectroscopy that offer detailed information about tissue microstructural and biochemical composition. Laboratory-based and emerging imaging technologies continue to expand our capabilities, promising even greater insights into biological processes and disease mechanisms. Today, I'm mostly going to talk to you about magnetic resonance imaging. So both structural and functional techniques. The other are very important, and I invite you to read more about it in the biography. We have to redo the last part of this slide, so I'll just continue for now. The other types of imaging are also very important, and I will be providing further literature in the bibliography of this talk. Magnetic resonance imaging represents one of the most powerful and versatile tools in modern medical research and clinical practice. Today, I'll walk you through the key advantages that make MRI an invaluable technique in research. First, let's consider its remarkable spatial resolution. MRI provides exceptionally detailed images of soft tissue structures, allowing us to examine anatomical changes with incredible precision. This high-resolution capability is particularly crucial when studying complex structures like the brain. What makes MRI particularly valuable for research is its non-invasive nature and safety profile. Unlike other imaging techniques, MRI does not use ionizing radiation, making it ideal for longitudinal studies where we need to scan participants multiple times over extended periods of time. One of the most exciting applications is functional MRI or fMRI, lets us observe brain activity in real time. This capability has revolutionized our understanding on how different brain regions respond to stimuli and contribute to various functions. The ability to measure diffusion and connectivity through techniques like DTI has opened new frontiers in understanding neural networks. This allows us to visualize and analyze the white matter pathways, providing crucial insights into brain connectivity. MRI versatility is further demonstrating through its various modalities, including magnetic MR spectroscopy for biochemical analysis and diffusion imaging for cellular structure examination. Each of these techniques offer unique insights into different aspects of tissue properties. The high sensitivity to tissue composition and pathology makes MRI particularly valuable in detecting subtle changes associated with disease progression. Importantly, the fact that MRI can be repeated in multiple centers supports large-scale multi-center and collaborative studies. It has also the potential to discover non-invasive biomarker for pain. In conclusion, these advantages have established MRI as a cornerstone of medical and modern research, enable unprecedented insight into human biology and pathology. MRI offers a wide range of powerful techniques that provide invaluable insights. Some of them are the structural MRI, which allow us to study the anatomy of the brain, functional MRI, which is a cornerstone for understanding how the brain works, both at rest and during specific tasks, diffusion MRI, especially DTI, focusing on white matter pathways, MR spectroscopy, adding a biochemical dimension. And I'm going to talk to you a little bit about each one of these, how we can actually get this data, how we can analyze this data, and how can we actually apply this onto pain research. Structural MRI methods enable detailed examination of brain anatomy through sophisticated imaging processing techniques. The process typically begins with acquiring the image, following by pre-processing steps and advanced analysis. There are many methods for studying structural imaging using MRI. One of the most used methods through pain MRI research is cortical volume analysis. For us to be able to study gray matter cortical volume analysis, we can do both voxel-based and ROI-based analysis. And this is probably what you can easily find in the literature: voxel-based morphometry or region of interest-based analysis. VBM, or voxel-based morphometry, offers whole brain ability of analysis, while segmentation provides anatomical meaningful measurements in specific regions of interest. Together, these approaches enable comprehensive assessment of brain structure in both research and clinical applications. Cortical thickness involves measuring the distance between the white matter surface and the pile surface at each point of the cortex. This measurement provides detailed information about cortical structure and can be analyzed using surface-based methods that account for the folding patterns of the brain. The gyrification index analysis quantifies the amount of cortex buried within sulcus folds compared to the amount visible on the outer cortical surface. This analysis provides us more detailed measures of folding patterns in specific regions. They can be particularly useful in studying neurodevelopment conditions or brain maturations. Both analyses typically involve surface reconstruction from high-resolution T1 weighted MRI scans. We can measure in terms of structural more than the cortex. Namely, the subcortical structures can also be analyzed structurally looking into MRI indices. There are various ways to look into subcortical structures. One of them, volume, the other, also very known, shape analysis. This type of analysis involves examining deep brain structures using specialized automated tools that can segment and quantify these regions. Volume analysis typically begins with automated segmentation of subcortical structures, such as the hippocampus, amygdala, thalamus, from the T1 weighted MRI scans. There are several tools, like FIRST, which is part of FSL or FreeSurfer, that can automatically identify and measure the volume of these structures. Shape analysis go beyond simple volumetric measurements by examining the three-dimensional surface geometry of subcortical structures. This approach can detect localized changes in morphology that might not be apparent in overall volume measurements. Methods include vertex-based shape analysis and spherical harmonics techniques, which can characterize subtle differences in the shape of subcortical structures between groups or over time. These analyses are particularly valuable in studying neurobiological and psychiatric conditions where subcortical structures might be affected, providing detailed information about both global and local structural changes. The analysis of subcortical structures has been particularly important in the pain field and chronic pain research field. The following table summarizes key structural brain changes observed in various chronic pain conditions, divided into cortical and subcortical regions. Let's start with cortical regions. These are just a few of the changes and a few of the discoveries that have been made over the past 20 years. Much more exists, and this is illustrative of the importance of all these metrics in our field. As you can see in the first image, in the prefrontal cortex, studies have found decreased gray matter volume in chronic back pain patients, as shown by Apkarian and colleagues, using voxel-based morphometry. The anterior cingulate cortex shows reduced cortical thickness in fibromyalgia, while the insular cortex demonstrates decreased gray matter volume in chronic low back pain. Interestingly, the somatosensory cortex show altered girification patterns, specifically in trigeminal neuralgia. Moving to subcortical regions, we see several important findings. The thalamus shows reduced volume in chronic low back pain patients, as demonstrated by Apkarian's group. The hippocampus shows decreased volume in both chronic low back pain and complex regional pain syndrome. The amygdala demonstrates reduced volume in chronic back pain patients, while basal ganglia, particularly the putamen, shows both altered shape and reduced volume in chronic migraine patients. These findings collectively demonstrate that chronic pain conditions are associated with significant structural changes throughout both cortical and subcortical brain regions, highlighting the widespread impact of chronic pain on brain structure. Longitudinal analysis of structural brain changes represents also a very powerful approach to understanding brain plasticity in chronic pain conditions. Unlike cross-sectional studies that provide only a snapshot in time, longitudinal studies can track changes within the same individuals over time, offering unique insights into both the development of chronic pain and potential recovery. Looking at some of the key studies in the table, we can see an important progression in our understanding. starting with Baliki et al., 2012, demonstrated decreased gray matter density in several key regions, including the insula, primatosensory cortex, and medial prefrontal cortex in chronic back pain patients. Over time, this foundation work helped establish the structural impact of chronic pain to the brain. Moving to the last study in this table, Seminovic's 2013, we see a particularly encouraging finding. Brain changes can be reversed when chronic pain is successfully treated. This study demonstrated the brain's remarkable plasticity and potential for recovery, showing that structural alterations are not necessarily permanent, but can normalize with effective pain treatment. Using structural longitudinal studies collectively add to the field of chronic pain and demonstrate that chronic pain induces dynamic changes in brain structure, and importantly, these changes might have the potential to be reversed with successful treatment. Next, I'm going to introduce to you to the field of functional imaging. How does functional imaging also actually works? Following this image that was adapted from the paper cited below, the neurovascular coupling mechanism underlying the functional MRI methodology involves a complex interaction between neurons and microvasculature. When neurons become active, even during resting state, when no task is being done, they trigger a cascade of molecular events involving glutamate release, calcium signaling in multiple cells around. Astrocytes and other microglial cells, through their end-feed processes, contacting the capillaries and pericytes, regulate local cerebral blood flow through vasoactive mediators. This neurovascular coupling leads to the hemodynamic response, characterized by an increase in cerebral blood flow that exceeds oxygen consumption. This results in a local decrease in the oxyhemoglobin concentrations due to the influx of oxygenated blood. Given that the oxyhemoglobin is paramagnetic, this decrease creates a measurable change in the magnetic susceptibility. The bold response, which we can measure with fMRI, reflects these changes in the ratio of oxyhemoglobin to deoxyhemoglobin. The characteristic temporal profile, shown as an initial dip, followed by a positive peak at approximately 4 to 6 seconds post-neural activity, and a subsequent undershoot before returning to baseline. During the resting state acquisitions in fMRI, we focus on spontaneous fluctuations in this bold signal, occurring at frequencies between 0.01 and 0.1 Hz, which reflect intrinsic brain activity patterns. There are several ways to measure activity from the bold signal. Here, I'm presenting some of the major approaches that can be used. ALF, seed-based connectivity, and independent component analysis are probably the ones that are most known to you. ALF, or amplitude of low frequency fluctuations, is a key analytical method used in resting state fMRI research that quantifies the intensity of spontaneous brain activity by measuring the amplitude of low frequency, bold signal fluctuations. This technique provides a voxel-wise measure of the strength or intensity of spontaneous neural activity during rest, making it particularly valuable for identifying regions with altered baseline brain function. ALF analysis involves calculating the square root of power spectrum at each frequency, averaged across a specific low-frequency range, providing a direct index of the magnitude of regional spontaneous neural activity. This method has proven especially useful in studying various neurological and psychiatric conditions, as it can detect subtle changes in brain activity patterns that might not be apparent during other analytic or through other analytical approaches. Seed-based connectivity, as shown in the first part of this image, reference of the paper below, shows that seed-based connectivity analysis is an approach where we examine functional connections between brain regions by measuring the temporal correlations in bold signal fluctuations. By acquiring bold signal fluctuations in different regions, we can select a given seed and correlate it with another given seed, or correlate it with all the other voxels in the brain. Typically, a specific brain area hypothesized to be involved in a network of interest is selected as the seed. The average bold time series from this seed region is then correlated with the time series of all other voxels in the brain or another seed of interest, creating a connectivity map. This approach reveals which brain regions demonstrate synchronized activity with the seed region during rest, providing insights into functional brain networks. While straightforward and hypothesis-driven, seed-based analysis is particularly valuable for investigating specific neural circuits and has been extensively used to study chronic pain. Finally, graph theoretical metrics. Graph theoretical metrics in functional MRI provide a powerful tool for characterizing complex brain networks. These metrics, as I show you, quantify various aspects of brain organization, including local and global efficiency, clustering coefficient, path length, and centrality measures. In the context of functional connectivity, these measurements help us understand how different brain regions communicate and form networks. With metrics like degree centrality, we can identify hub regions that have a large number of connections. And modularity reveals community structure within brain networks. This approach has been particularly valuable in understanding brain network organization, as I will show you in coming slides. Another technique highly used in the field is the task-based functional imaging. Task-based fMRI measures brain activity during specific tasks. Here I'm showing a functional MRI paradigm for efficient mapping of memory. By detecting changes in blood oxygenation through the bold response, when neurons become active during a task, as they trigger a neurovascular coupling cascade, neural activity leads to an increased local blood flow, which changes the ratio of oxyhemoglobin to deoxyhemoglobin. This creates a measurable bold signal that peaks, as we've been through before. This allows us to map which brain regions are engaged during a specific cognitive or behavioral task. The core of the analysis involves using a general linear model to identify brain regions that show significant activation during the task. In this figure, we can see a scheme of a task paradigm. The order of presented stimuli and sensory conditions is shown in the first part of the figure. On represents the presentation of a stimuli, and off represents no presentation of stimuli. Each block contains 5 stimuli of one category and lasts for a given period of time. In this figure, we can see the results from the analysis from the first task-based activity shown. Task-based activity contrasts between auditory and visual and environmental and vocal sensory conditions can be seen in the figure. Task-based fMRI has been highly used both to study nociception and acute pain in the scanner by using different types of nociceptive stimuli, but also to study other brain functions and relate them to pain, as I will show you. Here we have some examples of functional imaging using task-based protocols. The first example, Boninger et al., focuses on a somatosensory focus task, alternating blocks of focusing on painful and non-painful body areas. They show that increased activation during focus on neuropathic pain in brain regions associated with somatosensory integration and representational knowledge. Wilcox et al. In 2015 applied, for example, a different type of stimuli, in this case, a cold pain stimuli to the right hand thenar surface. Participants continuously rated pain on a 0 to 3 using a button inside the scanner. This study identified brain regions involved with processing subjective pain during a specific cold stimuli application. There are many more, and this can be found in the bibliography I will be supporting with this talk. Finally, I'm going to briefly discuss two other techniques that are commonly used in pain research: diffusion teratography and magnetic resonance spectroscopy. Diffusion tensor imaging, or DTI, is a method that utilizes key properties that water molecules have. These properties are directed towards the dogma that water molecules move along white matter bundles faster than they do against them. The whole idea behind this method is that of diffusion in neurobiological settings. Diffusion is the movement of a substance from an area of high concentration to an area of low concentration. By measuring water diffusion in multiple directions, the location and trajectories of axonal bundles can be estimated and those pathways reconstructed using MRI techniques. One major strength of the diffusion techniques is that they can directly measure the anatomic structure. Nuclear magnetic resonance spectroscopy is another technique that resolves the chemical components of a sample, a method commonly associated with organic chemistry. Applied to neuroscience, MRS typically refers to a single voxel in vivo, where data from a single large volume is collected. MRS takes advantage of the specific chemical structure of metabolites and its effect on resonant properties of hydrogen nuclei to quantify the brain chemistry within a defined region of cortical tissue. While standard MRI uses the most abundant molecules in the brain, water and lipids, to create detailed spatial maps of brain anatomy, MRS focuses on low concentration chemicals. So unlike MRI, MRS in its basic form produces a spectrum rather than an image of the brain. The characteristic peaks and the throughs of an MRI spectrum show the strength of the signal as a function of its resonant frequency. Here I'm showing you some of the studies using DTI in chronic and acute pain. Moadi showed in temporal mandibular disorders that widespread white matter abnormalities potentially associate with pain processing and sensory integration. Importantly, Mansour et al. Showed that in subacute back pain patients, white matter abnormalities predispose individuals to develop chronic pain, potentially serving as a biomarker for pain chronification. Here, I show three studies that probe onto the use of magnetic resonance spectroscopy. These three studies investigated brain chemistry changes in chronic pain patients. The key brain chemicals they measured include acetyl-aspartame, which is a marker of healthy neurons, glutamate, an excitatory neurotransmitter, and GABA, which is an inhibitory neurotransmitter, and myoinositol, which is a marker of neuroinflammation. After reviewing with some detail the techniques that are available in imaging research, I'm going to briefly go over some of the applications. The literature in imaging and pain research has more than 20 years at this point and is extensive. I'm mostly showing some examples of how we can apply the techniques I've showed you to actually produce new knowledge and how this can actually be applied to clinical care. The experience of pain is more than the movement of nociceptive impulses through hardwired pain pathways from the periphery to the brain. The crucial journey actually occurs inside the brain through pain-relevant areas and top-down cortical-subcortical routes, as well as through the cortical-cortical highway, which gives meaning to the pain in terms of intensity, quality, and salience. The conventional view of pain processing in the brain, mostly involving somatosensory cortex, has evolved mostly due to neuroimaging in the past 20 years. This figure from Martucci's paper 2016 illustrates the key brain regions involved in pain processing and their specific functions. I have to tell you that a lot of this information comes from neuroimaging studies. Looking at the color-coded regions, we can identify several important networks. In red, we see the sensory, motor, and multisensory regions, including M1, S1, TPJ, which are responsible for encoding pain intensity, receiving nociceptive input, and integrating multisensory information. These areas show altered processing in chronic pain conditions. In purple, we have the pain effect and cognitive control regions, the ACC and the PFC, which regulate pain unpleasantness, context-dependent influences, and cognitive control of pain. The blue regions, including the nucleoaccumbens, amygdala, and related structures, are involved in emotion, value, and motivation, and show maladaptive pain-related emotional and behavioral responses in multiple studies of chronic pain. Finally, in green, we see the descending modulation pathway, including the periaqueductal gray, locus coeruleus, and rostroventral medulla, which normally controls pain, but as several neuroimaging studies show, becomes dysfunctional in multiple chronic pain conditions. The biological mechanisms enable us to observe not just the basic sensory aspects of pain, but also the emotional, cognitive, and behavioral dimensions as they unfold in the living human brain. Through this window into brain function, MRI can better help us understand how pain is processed, modulated, and experienced across its multiple dimensions. I will now give you a few examples on how we can apply brain MRI into pain research, both as diagnostic applications, monitoring changes with treatment, identifying mechanistic diseases processes, but also as prognostic applications. Can we identify neural markers of treatment response? Can we actually predict the transition from an acute to a chronic pain state? The mechanistic insights, the prognostic insights are still in an early age. It is important for neuroimaging to be associated with clinical metrics that we can easily apply in the clinical world. It is also important for neuroimaging biomarkers to help us phenotype patients. And this is what I'm going to show you a little bit about. Functional MRI can give us important mechanistic insights. In this influential study, Tracy Steam from Oxford demonstrated how cognitive distraction can reduce pain perception through specific brain mechanisms. They used a counting stroop task as a cognitive distraction while subjects received painful thermal stimuli. Key finds included that pain intensity scores were significantly reduced when subjects performed a more demanding interference task compared to a neutral task. This study provided some of the first neuroimaging evidence showing how attention can actually modulate pain processing through specific brain networks, particularly highlighting the role of the cingulum in the pain modulation through cognitive distraction. These methodologies can be applied in pain treatment. Another important study looking into the mechanistic insights that can be provided by brain imaging is this one done by Professor Zapkari and team at Northwestern. Here, they show for the first time that evoked pain in knee osteoarthritis engages different regions in the brain than the ones engaged during spontaneous knee pain. We can see that brain regions involved in spontaneous knee pain are mostly medial prefrontal limbic areas associated with emotion, reward, and learning circuitry. Here, and importantly, we can actually show the relationship between brain structural changes in osteoarthritis and a very simple, applicable in the clinic measurement, the neuropathic pain scale. Importantly, brain imaging has been able to identify neural biomarkers of treatment response. These remarkable studies demonstrate the reversibility of brain changes in chronic pain conditions. Let me highlight two key pieces of evidence. First, patients with hip osteoarthritis in the image on the left. In these patients, researchers found significant gray matter changes in the thalamus, a critical region in pain processing. Before surgery, hip replacement, patients showed reduced thalamus volume compared to healthy controls. However, 9 months after surgery, hip replacement, in this case, as I told, the thalamic atrophy had reversed, showing that effective pain treatment can normalize brain structurally. Second, Seminovics and colleagues provided compelling evidence of brain plasticity in chronic low back pain. Before treatment, patients showed decreased gray matter in several regions, including the dorsolateral prefrontal cortex, the anterior cingulate cortex, and brainstem. Following successful treatment, these same regions showed increased gray matter density, with changes visible as early as 6 weeks post-treatment and persisting at 4 months. Together, these studies reveal that chronic pain-related brain changes can actually be measured with functional MRI, and we can prove the reversibility of those. Another study using functional MRI showed the normalization of dorsolateral prefrontal cortex activity following successful treatment of chronic low back pain. And in a different study, functional connectivity and white matter structure in the insula normalized after treatment in patients with chronic low back pain, further elucidating the ability of neuroimaging techniques to probe onto changes in the central nervous system associated with successful treatment of pain. Here I show you some of the results in this study and further literature. Importantly, the brain can also be seen as a predictor of transition from acute to chronic pain, and functional imaging and structural imaging has been able to probe onto these aspects. A very important study by Dr. Abkarian's team in 2012 showed that the cortical striatal circuitry function predicted the transition from acute to a chronic pain state by following patients with subacute back pain over a period of 1 year with functional and structural MRI. The researchers could find that in the subacute pain phase, the connectivity between the medial prefrontal cortex and the nucleus accumbens could predict the outcome of persistent or recovering from the pain condition. Also, the anatomical characteristics of the cortical limbic system were able to predict and predetermine the risk for transition to chronic pain in this same population. Recently, we have showed that limbic structural properties are also predictors of pain persistence after knee replacement surgery. Importantly, though MRI and functional structural MRI and other important imaging tools can reveal a lot about chronic pain and should continue to be used, the modality combination and integration for better studying each component of what is the pain state is very important. Studying nociception can actually be done with functional MRI, but it is important to also not to forget about quantitative sensory testing, for example. Peripheral sensitization, spinal sensitization also rely importantly on other techniques, for example, electrodiagnosis. Sensory discriminative components of pain and descending modulation can also be studied using functional MRI, but important integration with physical performance tests and electrodiagnosis will give us more information. The cognitive evaluative aspects of pain will be importantly studied using a modality combination between fMRI, EEG, and neuropsychological assessments. And finally, to study the effective motivational aspects of pain, the psychological assessments as well as the patient outcome reported measurements are important. Summarizing, fMRI is a very interesting and important tool for the study of pain and the central nervous system. Its integration with other modalities is of high importance to potentiate the information given. The future directions of the field are multiple. Let me walk you through the exciting future directions of this neuroimaging field in pain science, which spans several key areas. In diagnostics, we are moving toward developing objective biomarkers for chronic pain. The goal is to identify specific neural signatures for different pain types using advanced imaging techniques. By combining multiple imaging modalities, we can provide diagnostic accuracy and better understand pain mechanisms. For prognostic applications, neuroimaging shows tremendous promise in predicting who might transition from an acute to chronic pain state, who might recover from a given intervention. By identifying brain-based risk factors and developing methods to forecast treatment outcomes and pain trajectories, we could revolutionize early intervention strategies. Methods to objectively measure pain intensity and quantify its emotional and cognitive components can also be addressed by using different aspects of neuroimaging. This includes assessing dynamic changes in pain-related brain networks, providing a more comprehensive understanding of the pain experience, and contributing to personalized medicine. In this topic, personalized medicine, neuroimaging has the potential to guide individualized treatment selection. By developing personalized prediction models, we can tailor those interventions to each specific patient's, potentially improving treatment outcomes. Technological advancements are crucial. We are combining different imaging technologies and standardizing protocols for clinical use. There is exciting potential in developing neuroimaging-based therapeutics, such as neurofeedback approaches. Finally, integrative approaches are becoming increasingly important. We are combining imaging with other biomarkers, conducting longitudinal studies, and applying advanced analysis techniques to better understand the complexity of pain processing and treatment responses. These developments promise to transform how we diagnose, treat, and understand chronic pain. Thank you for listening.